Good evening, ma'am. Hello, sir.
I am Akila.
Yes, ma'am. Can I start, ma'am?
Yes, ma'am.
Thank you.
Some black thing is on the screen. What is that? I don't know.
Ma'am, that is the screen sharing and in the upper part, ma'am.
It went off now.
Okay. Okay.
Okay.
Good evening, ma'am.
Good evening, ma'am. Tell me. We'll start.
Yes. A 21-year female patient, ma'am, presented with the chief complaints of imbalance while walking for 6 years, involuntary movements in both upper limbs and lower limbs in 6 years, slurring of speech since 2 years. Patient was apparently normal 6 years back. Then she noticed imbalance while walking, which is insidious in onset. Initially noticed swaying to right side, gradually progressive with subsequent swaying towards left within 1 year. Imbalance worsened over the next 2 years such that the tendency of the fall to sidewards increased and the patient was unable to walk for the long time. There is no history of aggravation of this imbalance while washing her face or while taking bath or while walking in dark places. She also had clumsiness of bilateral hands during approaching the glass of water while drinking and has frequent smearing of food over her face while eating. She also had difficulty in writing due to this clumsiness. She is having history of difficulty in negotiating foot into chapel, but there is no history of any difficulty in the slippage of the chapel or difficulty in gripping of chapels. There is no difficulty in mixing food. There is no difficulty in taking food to the mouth. There is no history of difficulty in sitting over the edge of the bed. There is no history of any stiffness of the limbs. There is no history of any hearing loss or ear discharge, nausea, vomiting, or head drilling sensation. And there is no history of any urinary disturbances. She also had involuntary movements in 6 years, which are brief, jerky, shock like movements, more in the lower limbs. Those are present both in the lower limbs as well as upper limbs, which are irregular, induced by which are present mostly during any activity like holding any object, writing, walking. But those are not aggravated by any like touch, sound, or visual stimuli, but gradually increased over the next year, because of which she stopped going to school also, and these jerks become more severe such that she could not perform activities as such as before, and these movements are not present during the sleep and rest. And there is history of slurring of speech since last 2 years, which is from the disease onset. After 4 years, she noticed patient attenders noticed, which is insidious onset, slowly progressive, which is in the form of like while when she is speaking, there is breakage of syllables, but it can be comprehensible. This is not associated any with any forceful nature of the voice, or not associated with any change in the voice and nasal twang. There is not. It is also not associated with any dysphagia or regurgitation of the food. After 5.5 years after from onset of the imbalance, she had history of involuntary movements of the both hands and the legs, tonic clonic movements lasting for 30 to 40 seconds, which occurred on the same day, ma'am. 5 episodes in the same day, which are associated with the drooling of saliva and uprolling of eyes with some brief loss of consciousness for 10 to 20 seconds, and there is no history of any involuntary micturition. Uh, Negative history, there is no any blurring of vision, no drooping of eyelid or double vision, or any abnormal facial sensations or decreased sensations, or there is no deviation of any angle of mouth. And there is no history of any preceding fever or headache. No history of any for the 6 years. There is no history of any forgetfulness or behavioral changes. There is no history of any drug intake or the toxin exposures. No history of any joint pains or swellings or rash. There is no history of any abdominal pain, diarrhea, or constipation. Past history, there is no history of similar complaints in the past. There is no history of hypothyroidism. Treatment history, patient was on tab valproic acid 500 mg for twice daily since last 5 months when she presented to the hospital. Personal history consumes mixed diet, hepatite normal, sleep normal, bowel and bladder habits regular. Family history born out of non-consanguineous marriage, ma'am, achieved appropriate developmental milestones, and there is no history of any similar complaints in the family.
Okay. We'll start analyzing the symptoms.
Yes.
It's not family history, no?
No family history, ma'am.
So how many siblings she has?
Only one brother, ma'am. Younger brother, 17 years of age. Patient is, he is also normal.
Parents are all right, no?
Parents are all right, ma'am. There is no issue. There are no complaints from the parents.
Okay. So imbalance while walking, you know, I am sure you know, you are very familiar with the symptom. Still, we will just for the completion, we will try to localize various causes for imbalance, no?
Yes, yes,
You have told many of the points, but just we will quick rough completion we will do. So
okay.
imbalance while walking is gait ataxia.
Yes,
So is it side to side swaying, or is it a reeling, or is it just a bizarre gait or any stamping? Nothing is there, no?
no, ma'am.
So first, when there is a gait imbalance, whether it is cerebellar, whether it is sensory, or is it a pseudo imbalance which can happen in muscle weakness, abductor muscle weakness. So how to differentiate all these three, we'll see. And I'm sure you know the cerebellar common gloss, no?
Yes, ma'am. Yes, ma'am.
Common gloss, where the leg fibers are in the
Paleo-cerebellum.
cerebellum. So
Yes.
gait ataxia in cerebellum means it can be paleo-cerebellum
Paleo-cerebellum.
or flocculonodular lobe, inferior cerebellar peduncle, and middle cerebellar peduncle.
Yes.
So this and Burmese, there is little difference.
Truncal.
Yes, we'll try to find out how we localize in the cerebellum, then we'll go to sensory. Paleo-cerebellum, what are all the points, ma'am?
Paleo-cerebellum, the patient will be having predominantly only gait ataxia, madam. Patient can have this lower limb ataxia and gait ataxia will be there. In case of whether if it is neocerebellum, like
Ataxia without any other accompaniment.
yes, ma'am.
That
Yes.
is paleo-cerebellum.
Paleo-cerebellum.
Gait ataxia without any other accompaniment.
Accommodation. If it is neocerebellum, then three things will be involved, ma'am. Like
Cerebellum will come later because it doesn't produce gait ataxia.
okay, ma'am. Then inferior cerebellar peduncle and middle cerebellar peduncle, ma'am. Middle cerebellar peduncle usually middle cerebellar peduncle is connection from pons to cerebellum. So only one afferent tract passes, that is corticopontocerebellar tract. So the patient will be having spastic ataxia, ma'am.
So it is spastic ataxia. Only situation where spasticity and ataxia is going together.
Yes,
So
ma'am.
spastic ataxia. Agreed. Second,
Inferior cerebellar peduncle, he is having connections with like vestibular connections. It is having, ma'am. So the patient will be having like almost the inferior cerebellar peduncle ataxia is similar to the flocculonodular lobe. Patient will be having vestibular symptoms, wide swaying, reeling type of gait.
with the eye signs.
Eye signs will be there.
They can have vertigo also, central vertigo.
Yes, ma'am.
So good. So that is about the gait. What about middle? You wanted to tell about neocerebellum, no? Tell me what happens in
Neocerebellum, usually predominantly this upper limb incoordination, upper limb ataxia with head involvement will be there, ma'am. Like head titubation or head tremor will be there.
So it is olivodendrothalamic pathway, which is the most important tract passing through the superior cerebellar peduncle. Intention tremor. You do not get any dysarthria in superior cerebellar peduncle. So
Yes.
no peduncle will produce dysarthria, and no peduncle will produce cerebellar type of eye signs. Whereas vestibular type of eye signs happens in inferior cerebellar peduncle, but no gaze evoked nystagmus. You will not get it. Whereas you come to the neocerebellum, you get speech abnormality and you get eye signs of cerebellar involvement and upper limb incoordination more than gait ataxia. You kind of mild spillover gait ataxia due to the uncinate fasciculus of Russell. There is something called uncinate fasciculus of
Yes,
Russell.
yes, ma'am.
Cooking.
Superior cerebellar peduncle connection, efferent connection.
Yes. What about the vermisma?
Vermis, the patient will be having truncal ataxia, ma'am. Difficulty in sitting over the edge of the bed.
Truncal ataxia and titubation.
Titubation.
Then which part of the cerebellum is controlling language?
Language, cerebrum. Actually, language center is dominant cerebral hemisphere. In case of cerebellum, it is not like right inferior paravermal area control from the cerebellum controls language, and the prosody is by left cerebellum.
Very good. So that is the opposite of the cortex.
Cortex.
Very good. So apparently this history the patient is telling, you will think probably it's a paleocerebellar because it looks like a gentle swaying and not a reeling gait which will be so obvious and drunken. It doesn't look like that.
Yes,
So
ma'am.
quickly tell the sensory ataxia. Quickly revise sensory ataxia.
Sensory ataxia, the patient will be having subject to symptoms. The patient will be having, ma'am. Cerebellar usually subject to plus object.
Patient doesn't get an idea regarding the body part in space.
Yes, ma'am. They will see the
So
feet and they will walk.
He'll be very cautious. Good. Then in night it will aggravate. Which
Yes,
is
ma'am. Dark places will
and
aggravate.
the patient shifts his gaze from the feet. He will put his limb in bizarre positions because he won't know where it is. Unless you ask a question and he tries to answer you, then he'll put the feet in a bizarre position and then he will not know where is the flow. So he will bring it down with a stamp. So it's a attacks imbalance, which is cautious, bizarre, and makes the gaze fixed on the floor. And if he is diverted, he brings down the leg with a stamp. What about pseudoataxia happening in proximal muscle weakness?
There will be hip up strain or hip down strain.
It's a waddling gait.
Waddling.
So can say he is swaying because every time he puts the leg forward, it dips and patient sees to that side. Normally, the pelvis on that side will go up. Instead, that pelvis comes down, now opposite of Trendelenburg effect. So they will say waddling, but the key point you should be telling is cerebellar features, whether it is finger nose incoordination or whether it is a gait ataxia. It is not a terminal one. It is not a distal one. It's a proximal. The whole body will sway. Cerebellar, the whole body will sway. Whereas waddling is only the pelvis. For the patient, they will not know. So you'll see whether the gait is a waddling gait, which is many times mistaken if you do not know and if you do not ask. CIDPs may be treated as some. You carefully look and you find some cerebellar folia is prominent and label it as a degenerative disease where it may be a correctable disease. So it is very important. So that is a waddling. It is not the whole body. All cerebellar syndromes are proximal and whole body, including the tremor. Tremor is not a terminal clumsiness. It is a whole limb will move forward and backward. So whole limb. So that is the thing. So it is steadily deteriorated. So it's a progressive disease. No?
Yes, ma'am.
Steadily deteriorated. It's not acute onset.
No, ma'am. No, ma'am.
Relapsing remitting. In this age group, if it is an acute cerebellar syndrome, you will think of vasculitis, you will think of demyelinations, no? Yes, even mass lesions you can think. But headache, ICP is not there. So it is slowly progressing bilateral symmetrical.
Yes.
So it looks like a degeneration.
Yes.
I think that progressive diseases we put under 3 categories. One is degeneration, second is slow virus, third is tumors. Tumors will start producing ICP features after some time. Slow viruses have got characteristic syndromes like Jesman-Straussler syndrome, CJD group of disorders, no? And progressive measles encephalopathy. So those things are having a little more shorter, more aggressive course. So third is this one, degeneration. So apparently the person is having a quiet disease. So looks like it will fit into a degeneration, being symmetrical, very slowly progressive. And she is unable to walk for long distance with aggravation of symptoms. So is it having a length dependent feature? Long distance, is it like a
No, no, ma'am, not like any NM junction, not like that. Like patient is unable to walk for long time means like long distance without support. She is unable to walk. I framed the sentence.
But is there anything like when she starts, she's all right, and after exertion, she's worsening like that? Anything is there? No.
No,
No.
ma'am, no, ma'am. Only turning some problem is there. Able to
Okay,
turn
okay.
like she takes
So
some
take off
time to.
that and say long distance, she may be feeling tired because she's having a poor balance. She may be very cautious and putting more effort to walk. So she may feel tired. Instead of saying that after long distance, her imbalance worsens. No, after long distance, unlike normal people, she may be feeling more tired because energy spent will be more to make a cautious gait to avoid fall. So that sentence slight modification we'll do.
Okay, okay.
Otherwise, it will look like a exertional ataxia. Yep. So exertion-induced aggravation of ataxia happens in some conditions. You see, like
Paroxysmal kinesis.
paroxysmal kinesiogenic dystonia. That is a dystonia. You can get in mitochondrial disorders.
Right.
Exertion-induced worsening happens. Sometimes even in craniovertebral junction anomalies. When you walk fast and your head position changes, they can get ataxia that might settle down. So instead we'll say that after walking for a long distance, she is unable to continue her regular walking. That will be the ideal sentence. Okay. And then you said she developed upper limb
This
feature.
upper limb features, ma'am. Then this shock-like movements are there, jerky movements.
Upper limb will be neocerebellum or it is a superior cerebellar peduncle.
Superior cerebellar peduncle.
But she develops slurring of speech.
So localizing to
the cerebellum only.
yes, yes, ma'am.
So speech and eye signs do not happen in peduncle. So
Peduncles.
you can apparently call it as a pancerebellar syndrome at this point of time.
Yes.
Whether the flocculonodular lobe is involved or not, we do not know, we'll examine. But apparently it looks like a symmetrical pancerebellar. Symmetrical. Then these jerks, so describe those jerks.
That's the patient from the 6 years. After this imbalance, they notice the jerks, ma'am. Actually, they're telling both this while approaching the glass of water, she is having upper limb incoordination. Along with that, she is also having this jerky movements during the like only while any approaching to object or holding object or writing or like walking only. She is having both in the lower limbs as well as in the upper limbs, madam. Because of that, she stopped going to school also. So. Because of this jerky movement, so I want to tell these movements as possibility of myoclonus, mostly action myoclonus.
Okay. How do you define myoclonus?
Myoclonus is involuntary arrhythmic jerky shock-like movements involving the musculature. It can be positive or negative.
So you want to use the term musculature in between. It's not muscle disease, no. So you can tell that it is a sudden shock-like movement involving a single muscle or a group of muscles or the whole body. The musculature term you don't use. It
Okay.
may be taking place at the level of a single movement, like finger extension or flexion like that, or it may be a wrist or one limb, and it may throw the patient to the ground with or without loss of consciousness. So sudden shock-like contraction that you tell it is there of a single group of muscles or a one limb or the whole body with or without loss of consciousness. So when there is loss of consciousness, we call it as an epileptic myoclonus. When there is no loss of consciousness, you call it as a non-epileptic myoclonus. So apparently this person seems to have a non-epileptic myoclonus. So this myoclonus, then you, after deciding it is non-epileptic, how do you categorize them? Cortical,
cortical,
Cortical
subcortical,
and spinal.
and subcortical, and
Spinal.
spinal myoclonus and peripheral myoclonus, ma'am.
Yes.
Usually, cortical myoclonus will involve the distal limbs as well as the face, and it will be stimulus sensitive myoclonus. Subcortical
Cortical
myoclonus
myoclonus is usually stimulus sensitive. Agree?
sensitive, and subcortical myoclonus involves the proximal and can be distal also, and it can be also stimulus sensitive, but the thing is that the proximal part of the limbs can be also involved in case of subcortical myoclonus. Spinal myoclonus
Hello, Krishna.
can be segmental and
Hello, no.
propriospinal myoclonus, and the spinal
అన్న
myoclonus can
అన్న
be
అప్పుడు నేను
present
జూమ్
during
మీటింగ్ లో
the
ఉన్నాను. నేను
sleep
ఒక హాఫ్
also.
అన్
Spinal
అవర్
myoclonus can be
అర్జెంట్
present during the sleep also, ma'am.
నేను
Peripheral myoclonus is due to this involvement of the muscles or any nerves atrophy causing some like polymini myoclonus. Like
So cortical myoclonus, as you said, it is generally a very quick myoclonus. Second, it can be stimulus sensitive. Third, it is usually focal or multifocal. Focal or multifocal, and it shows a descending pattern, as you told. So you told correctly only, but I thought you will ideally use the correct word, that it descends from above below. Whereas subcortical myoclonus is a slow myoclonus. And subcortical myoclonus is, as you said, it is usually symmetrical. Unlike the cortical myoclonus, which can be focal or multifocal, subcortical myoclonus is slow myoclonus, generally symmetrical. There can be stimulus sensitivity, but it is very less common. And usually it will start below up, ascends. Because from the subcortex, it goes to the cortex. And then when you do the EEG, you will find that the EEG and EMG are time locked in cortical myoclonus. Whereas in subcortical myoclonus, the EMG discharge precedes the EEG discharge. So EMG discharge will come first and then the EEG discharge comes. So that is between cortical and subcortical. Spinal myoclonus, as he said, it can happen in multiple conditions, viral infections of the spinal cord, even tumors, and even slow HIV conditions. So you can get a segmental spinal myoclonus, or you can get a propriospinal myoclonus where the whole trunk might bend. Then, as he said, distal mini polymyoclonus, which is metabolic or recurring peripheral nerve disease when there is a repair mechanisms are taking place, like Guillain-Barré syndrome or any chronic acute peripheral nerve disease. When they are recovering, they can get that. So this is a non-epileptic. You think it is cortical or subcortical?
predominantly involving the distal part of the limbs, ma'am. So as of now, we can't say whether it is cortical or subcortical, because visual stimuli is
Classical example for a subcortical is SSP.
yes.
You see? Classical example for a cortical is juvenile myoclonic epilepsy of Jones.
Progressive myoclonic epilepsy spectrum.
Yes. So there you get a quick jerk, very quick, not slow. So apparently it looks like a cortical one.
Cortical myoclonus.
Examination, we will see whether there is stimulus sensitivity and all. Not necessarily it is always multifocal. So you have a pancerebellar involvement. Next you are getting a
myoclonus.
probably a cortical myoclonus.
Then only a speech disturbance already we discussed.
I tell that you have to describe the rate, range, rhythm, direction, amplitude, precipitating factor, relieving factor. So you have told it is distal, it is not proximal. Range is again distal only. Rate is probably fast, because short segment apparently.
Yes.
You see, more than 8 hertz, you call it as fast movement. Less than 8 hertz, you call it as a slow movement. And is there any auditory or touch or sound or light, anything that is unmasking it, you can say. Then any that will be a precipitating factor. Relieving factor, you told that it is relieved by sleep. So it is not there in sleep. So okay. Next you told next, what is the symptom?
Speech, ma'am. Speech, we already speech possibility of cerebellum we have localized. breakage of cerebrals.
dysarthria? What are the types of dysarthria? No.
Types of dysarthria: one is spastic dysarthria, flaccid dysarthria, hypokinetic, hyperkinetic, mixed, and cortical dysarthria.
Flaccid.
Cerebellar dysarthrias.
No, flaccid also, no? So we
Yes,
call
ma'am, flaccid also.
spastic, flaccid, ataxic, dyskinetic, cortical. So spastic, flaccid, ataxic, dyskinetic, cortical. Spastic is effortful. He squeezes out the words and there is a slurring, and like a hot potato in the mouth, they will speak. Flaccid is, it may be labial, lingual, gutturals, or dentals. Depending on whichever structure or more than one is affected, speech gets altered accordingly. Ataxic may be staccato or scanning. Dyskinetic may be hypokinetic or hyperkinetic. Hypokinetic is low voice volume of Parkinsonism. Just like the micrographia, it's a manifestation of bradykinesia. As the patient keeps on talking, the voice volume sings and sings and sings. Hyperkinetic may be choreic speech, lingual dystonias, tongue tremors. That is all hyperkinetic. Then cortical is a childish speech. We have a way of communicating things. So it becomes a lulling, whereas the meaning, everything is retained. So it's a childlike speech. So that is the various type of dysarthria. When you say slurring, we think that at this point of time, we do not know what. Slurring is the word used when there is an uncharacterized speech disorder, and you will characterize it when you examine the patient. So next, what is the next symptom? You told seizures, no?
Yes, ma'am. Only one day patient had seizures.
So she had 5 attacks in the same day.
Yes, ma'am. Yes, ma'am.
So what do you define status as?
Actually, that 5 episodes are also not at the same time, madam. In the complete morning and afternoon, like that, 5 episodes were happened.
How do you define status? And what term you will use to this patient's seizures? Would you like to define epilepsy, ma'am? We'll use this.
Epilepsy is at least 2 unprovoked seizures, which is 24 hours, which is greater than 24 hours apart, ma'am. Or else at least one unprovoked seizure, and the possibility of the further risk of the seizures of 60% when compared to the normal 2 unprovoked seizures in the next 10 years. And the other thing is the diagnosis of an epilepsy syndrome.
Okay. What is the difference between seizure and epilepsy?
Seizure is a single episode, ma'am, which is due to abnormal excessive hypersynchronous excessive electrical activity in the brain. Only one episode. Epilepsy is, it can be more than 2 episodes.
Yes, seizures are paroxysmal. They are paroxysmal disorders, no?
Yes.
Paroxysmal alteration in motor, sensory, psychic, or autonomic function, or all of them. So paroxysmal alteration in motor, sensory, psychic, or autonomic function, or all of them due to paroxysmal cerebral dysrhythmia. Non-epileptic attacks are paroxysmal alteration in the same things, which is not due to a paroxysmal cerebral dysrhythmia. That's the difference between non-epileptic attacks. And as you say, when there is a tendency to recur, you call it as epilepsy. When there is no tendency to recur, you call it as an acute symptomatic seizure. It may be head injury, hypoglycemia, electrolyte imbalance. Those things are acute symptomatic seizures. So when do you call a seizure as status? What is the current definition of status epilepticus?
One episode of seizure lasting for more than like T1, T2, the T2 will be 30 minutes and T1 5.
Which one, ma'am? What is T1, T2?
The T1 is the for the first seizure, and the continuous episodes of the seizure lasting for up to how many? minutes.
How many minutes?
That is T2
How
definition.
many minutes, ma'am? How many minutes?
30 minutes.
Is the oldest definition used to be a single seizure which lasts more than 10 minutes or repeated seizures without gain of consciousness in between. That's a very old definition. Single seizure lasting 10 minutes or repeated seizures without regain of consciousness in between. Whereas the current definition of status is any seizure which needs intervention to settle down. You see, people might throw a seizure for 1 second, 2 seconds, 1 minute, but they get up on their own and walk away. That is not a status. So current definition of status is not based on time duration. It is based on the need for intervention. So any seizure which needs an intervention to recover is called status. So it's very important. So in this patient, what you will call it as? You call it as a clustered seizures. So he gained in between and he became normal and again through. So these are called clustered seizures. So one patient has got an episode of clustered seizures. So where are you going to put the pathology for that? We have got a pancerebellar syndrome and we have got a probably a cortical myoclonus. Now you are getting a clustered seizures.
Cerebral, diffuse cerebral cortex.
So it again qualifies that the old myoclonus itself must have been cortical myoclonus. So it looks like so seizures come from the cortex only.
Yes.
At this point of time, so being a common disease, would you like to tell a little bit about the origin, spread, and arrest of seizures? This being a very common condition, which we can easily manage many times. There is mismanagement with so many polytherapies. Even when it is medically, one cause for medically refractory seizures is wrong choice of drugs, wrong dosage, drugs which do aggravate and reduce the effect of the other one, non-balanced drugs you put, that kind of things, no? So, would you like to tell quickly the pathogenesis of epilepsy in general? Each epilepsy has got different channelopathies and all those things. But generally, what happens to an epileptic neuron? An epileptic neuron, you know, a neuron has got dendrites and axons, no? So what structure becomes affected in an epileptic neuron? Dendritic spines. You know, dendrites have spines. And that dendritic spines are the ones with which the dendrites connect with the neighboring neurons, like a lock and the key. So dendritic spines are absent. So mainly it is a disease affecting the structure of the dendrites due to so many causes. It may be acquired cause, it may be genetic cause, it can be various channels, so many things are there. But what ultimately happens is dendritic spines are absent or destroyed. When they are absent, what happens? It is no more obeying the rule of the principal. You see, supposing you are college principal and we are all connected, some peon will come and tell us the message, we obey the message, no? So when the dendritic spines are absent, that neuron is no more getting information from the pacemaker of the brain. Which is the pacemaker of the brain? It is the thalamus. So it will be automatic. So dendritic spines are absent. So the neighboring neurons are unable to convey their status to this neuron. So when the dendritic spines are absent, there is a failure of the neurochemical balance. Because it is all flowing, electricity is flowing, chemistry is flowing, so that there is some uniformity in function. So when the dendritic spines are absent, the electricity fails and the chemistry also fails. Because they are no more influenced by what is going on in the neighboring neurons. So EPSP, heard of? excitatory postsynaptic potential. That is more than IPSP. Normally, EPSP and IPSP are in balance. When the dendritic spines are absent and the neuron gets autonomy, the excitatory postsynaptic potential is more than inhibitory postsynaptic potential. And chemically, glutamate is more than glycine. So everything is favoring excitation. But a single neuron cannot do anything. So that's an epileptic neuron, it is there. Slowly, this electrochemical abnormality of one neuron destroys the balance in the neighboring neurons. And the time taken for an epileptic neuron to convert into an epileptic focus is called maturation time. So there is a period. The number of neurons which are sick, that is why we tell that post-traumatic epilepsy becomes a condition for compensation only if the epilepsy comes within 1 year of head injury. That means that much nerves have been destroyed. So it became an epileptic focus within 1 year. But if the focus takes very long time, you are no more eligible for compensation. So the time taken is the maturation time. Then what happens? There is something called paroxysmal depolarization shift. When an epileptic focus is formed, it produces a migrating electrical front, which is called PDF or paroxysmal depolarization shift. And this travels by association fibers and commissural fibers. You have got anterior commissure, corpus callosum, posterior commissure, long association fiber, short association fiber. So intra-hemispheric spread takes place by the association fibers, and cross-hemispheric spread happens by the commissural fibers, and then the focal seizure becomes generalized. When it becomes generalized, patient loses consciousness. So that is, then what happens? So this is the spread, origin and spread at structural level. The cause of this, as I said, it can be genetic, it can be chemical, it can be metabolic, it can be channels, so many things. Then how does the seizure gets arrested? If it arrests only, we call it as a seizure. If it doesn't arrest, you call it as a status. No? So how arrest happens? When the substrate which provides the glutamate might get exhausted. So there is no more excitatory neurochemical available. And there is accumulation of inhibitory neurotransmitters and inhibitory substances that will chemically act. And third will be diencephalocortical inhibitory reflexes. When the seizure has spread, body immediately senses and sends from the diencephalon to cortex. They are called diencephalocortical. You told tonic, clonic. You told a tonic phase is the excitatory. Only excitation is there. Clonus starts when the diencephalocortical inhibition is taking intermittent control over the cortex. So intermittently, the diencephalocortical reflexes are going, that produces the clonus. Again, the focus takes charge, then it becomes the tonus. So clonus is the diencephalocortical inhibition. So repeatedly, clonic inhibition is taking place. That is why after the seizure, patients become tired and they sleep off because of over inhibition. Clonic effect on the cortex becomes very strong. So patient becomes tired, sleeps off, and they may become flight. And these autonomic features of seizures produce excessive salivation and drooling. So that is the arrest of seizure. If the diencephalocortical inhibitory reflexes and excitatory neurotransmitter exhaustion doesn't take place, means patient goes on to a status. So that is brief anatomy of seizures, because generally we don't discuss seizures. So I thought we'll do that. So this looks like a myoclonic jerks going in for generalized seizures, probably. It looks like generalized. There is no aura, no?
Yes.
Did the person have any aura or anything?
Aura, they are unable to tell the aura, ma'am. Actually, this has happened 6 months before the presentation. They only told about the movements and
Yes. What is aura? Yes, aura is means it will point your focus. Whereas aura is not there means it is generalized. So how do you define aura?
aura.
Aura is, you see, normally they may say stereotyped, they see a snake. Or stereotyped, they see some environmental change. Stereotyped, they get an olfactory smell, or some panic, depending on the site of the neuraxis that is involved. So I have heard patients telling, maybe he saw a snake in childhood. After that, every time he thinks of the snake and tells someone snake is coming, he faints. Snake is the aura. It will be stereotype. That comes from the so aura is that part of the seizure for which awareness is retained. So patient will know. He will only tell, Amma, I am seeing a snake. Or they get a panic, epigastric sensation, which are sense. They get panic. Come running and hold the mother. So they will say, he got frightened somewhere, something, somebody threatened him, after that he is getting. Like that, they will draw conclusion. So aura is that part of the epilepsy for which awareness is retained. And it helps us to localize and differentiate between generalized epilepsies and localization related epilepsy. There is another component, automatism. What is automatism?
Automatism or abnormal abnormal movement. It can resemble the motor manifestations of a seizure. It can be like oro elementary manifestations or like uh, versive automatisms or uh, like picking, fumbling of objects, dropping of object.
Mm. Good, you know what it is. So the definition is automatisms are involuntary responses of the patient, motor responses of the patient to illusory internal or external stimuli. So involuntary motor automatisms of the patient to illusory internal or external stimuli. Because illusory internal means chewing, swallowing, sucking, for which there is no awareness. Patient will not know. Unlike aura, so automatisms are involuntary motor activities of the patient secondary to illusory internal or external stimuli for which awareness is not retained. So they cannot tell it. You only have to tell it. And internal stimuli, chewing movement, sucking movement, swallowing movement, gustatory activities. External, as you said, they will be pricking, trying to pick objects, search something in the floor. So that is the external stimuli, but they will not be able to know. Others only will tell he is doing so many mannerisms, but when you call, he is not responding. After that, he becomes unconscious. That is automatism. So those things are not there. So probably this is a generalized seizure. Okay. Then what else? That's all. So now my patient is having a pancerebellar syndrome. Second, she is having probably cortical myoclonus. And third, she is having seizures. So this clubbed together, what do you call it as?
Progressive myoclonic first differential kept as progressive myoclonic ataxia spectrum disorders, ma'am.
Yes.
Because the patient is having seizures, generalized seizures, but that is only one day they are complaining of the seizures, and predominantly there is no cognitive decline is also not there, so it can be grouped under progressive myoclonic ataxia spectrum. If its seizures are predominant and with cognitive decline is also there, then we can group it under progressive myoclonic epilepsy spectrum.
Agreed. So that becomes the first possibility, and probably that's this unique combination you will consider that only. And what are the other conditions where there is ataxia, myoclonus, and seizures?
Ataxia myoclonus seizures. One, if the family history is there, ataxia with myoclonus can be seen in a spinocerebellar ataxia like SCAR 12, ma'am, and SCAR 10 can have seizures. And DRPLA, which is autosomal dominant, it can have seizures, ataxia with chorea as well as myoclonus and dystonia. And ataxia with myoclonus, chronic progressive, if it is
PME
chronic,
syndromes, various group of PME syndromes, no?
yes, PME syndromes like Lafora body disease, Unnervich-Lundborg disease, neuronal ceroid lipofuscinosis, sialodosis, and mitochondrial disorder, which include MERF, is placed in the myoclonic epilepsy with red ragged fibers, which comes under progressive myoclonic epilepsy spectrum disorder.
Very good. So, clubbing all the three cardinal features, you categorize all the syndromes coming under that. But most of these progressive PME syndromes have cognitive decline. So
Yes.
it's not there. So you rightly call it as progressive ataxia myoclonus syndrome. And you have started valproate, no? Even
Yes,
though
ma'am.
even though it is true that there should be cognitive decline in MERF also, where there is a mitochondrial encephalopathy, no? But better when there is a suspicion to be cautious, do some forearm exercise, lactate ammonia, and then give valproate, because valproate is a mitochondrial poison. It comes under that, I am sure nothing is impossible in medicine. And in this spectrum, it need not be always, because mitochondrial encephalopathy, ragged red fiber, you will see only when you do the biopsy. That encephalopathy can manifest as cognitive decline, but it need not be very obvious. What is the occupation, educational status, and requirement of this patient in function may be very minimal. Then she may not tell. So it is always safer not to use when one of the condition comes under mitochondrial. It's a very wide spectrum. Mitochondrial disease is a huge spectrum of disorders, and sometimes sudden death can happen. We have seen patients who suddenly died with a single dose of valproate. So better we can give an alternative drug. Levetiracetam might be helping, or the benzodiazepine group of drugs may be helping. Better to try them than then if they are not responding, because that spectrum is there. That's all the point I want to tell. What are all the features of Lafora body disease?
Lafora body disease, the patient will be having the age of onset usually will be 2 to 8 years of age, ma'am. The patient will be having
Little later also, not
later.
necessarily always very early. Yeah, you can have late forms also, second decade, early second decade, it can come. Yes.
Uh, multiple episodes of seizures will be there. GTCS, multiple types of seizures. It can be GTCS, can be also there. Myoclonic seizures also can be there, and the patient will be having cognitive decline also. Encephalopathy features will be there.
Agreed.
And investigation wise, we should think of this axillary skin biopsy is needed to look for any Lafora bodies are there, which are PA strained positive inclusion bodies.
Yes. You also have this cherry red spot myoclonic, so you can look for cherry red spot in the.
Yes, ma'am. Unnervich Lundberg, cherry reds. Yes, ma'am.
Okay, examine. So only thing, be careful when you select drugs when there is a category under this condition.
General examination, patient conscious oriented, cooperative to time place person, ma'am. Vitals are normal, BP pulse and respiratory rate, temperature. Then head to toe examination, there is no para-rectus or cyanosis, no clubbing, no edema, no telangiectasias over eye and or the nail beds are in the ear lobules, no tendon xanthomas, no cataracts, and no other neurocutaneous markers, ma'am. Higher mental functions, she is a right-handed person, conscious oriented, language fluency, comprehension, repetition, naming, reading intact, and writing because of this jerks, it could not be tested. Speech, mild scanning type of speech.
So the handwriting in cerebellar disease.
Cerebellar disease, my macrographia will be there.
Correct. So it's macrography.
Macrography.
Cerebellar disease, it is macrography. Myoclonus, it is like chorea. No? Every time the involuntary movement comes in, when the movement is not there, the handwriting doesn't get altered. Pure myoclonus without cerebellar disease. And the moment the myoclonus comes, either the pen gets pulled away, producing lines, or patient will move the pen away, so it becomes a stop there, dots. So chorea is also fast movement. No? So when the movement comes, patient might just get dragged through the pen, or there can be a dot. When myoclonus comes, they voluntarily try to control it. So it will be several dots every time the myoclonus comes or every time the chorea comes. Or it may be a drag. Cerebellar disease, macrography. Agree.
Speech mild, not complete, mild scanning type of speech is there, ma'am. I will show you the video once. MoCA is 24/30, ma'am. Coming to the cranial nerves, all the cranial nerves are normal except for the second cranial nerve when visual acuity, field, color vision is normal. Fundus examination, bilateral macular cherry red spot is there, ma'am.
Oh.
Coming to the motor, bulk, tone, power are normal in all the upper limbs, around all the joints, and in the lower limbs around all the joints. Reflexes are 2 plus with plantar bilateral flexor. And primary modality sensory examination as well as cortical sensations are normal. And cerebellar function test, there is a dysdiadokinesia is present, ma'am, and a finger nose test abnormality is there. Dysmetria is there with past pointing. Healy test is abnormal. Speech, some scanning type of speech is there, and there is no nystagmus, ma'am. This is the patient video. Here I'm checking for the any postural tremor is there. Patient is not having any postural
छाती से
tremor.
रखा दिया था एंत कर्म दिया था डाहन हाथ रे एंत करो
Checking whether some diseases can have bradykinesia with myoclonus and seizures. So whether any bradykinesia is there or not there.
डाहन हाथ रे
And some
पेन किछि
in
हुआ
between some
गुच्छे
myoclonic jerks are there. I am doing finger nose test. Here the patient is having incoordination,
गोटे
and
हाथ
in between there is a finger nose test is impaired along with
आंगुर नाको छु
the jerky tremor it is there. In between patient is having some myoclonic jerks.
बाहर करो पेन छु
Check cerebellar. No? Always very obvious. She is having a very obvious finger nose incoordination. Very it's not at all subtle, but always do like wide,
Okay.
not like this.
Yes.
Wide. This is a proximal movement. It is very obvious in this case, but some patients will have subtle incoordination. Always it's like
Here lower limb myoclonic jerks are there at the time of walking. And she is taking, because of the jerk she is getting paused, and wide base gait is there.
Also असम चलो बोले कि जाओ
agreed. Taken a fundus photograph.
Yes, ma'am. I will show you, ma'am. Other systems are normal, ma'am. This is speech, ma'am. Speech very mild.
अदर को
January, February, March, April, May, June, July, August, September, October, November, December.
So it's it may be mild change, but I cannot categorize
Yes,
it as scanning or staccato.
Yes, ma'am. Actually, the complaints are when compared to previously, before 2 years, the speech mild change in the nature of the voice is there. They are telling.
So we will also tell it is uncharacterized.
Yes, ma'am. Yes, ma'am. This is the fundus camera photograph of the patient, ma'am, having a bilateral cherry red.
Fundus, ma. How do you describe the fundus?
Fundus first we will see the optic disc, ma'am. From the disc, we will trace the blood vessel, and we will come to the peripheral part, seeing this macula, and in the center of the macula, fovea foveola.
So you will describe the disc, you will describe the macula, you will describe the retina.
Retina.
When we are students, now we should systematically see. So then only we will pick up all the features. So in the disc, cup. So what do you think the physiological cup in this patient? Physiological cup is a small depression in the center of the disc. So in this case, the physiological cup is not well visualized in these pictures. It's not, maybe when you are looking directly, you may be visualizing, but whatever it is, looking at these pictures. So it is a cup, color of the disc, contour of the disc, vessels crossing the disc, peridiscal space. Like that we describe. So physiological cup is not well seen. Color of the disc appears white. It is not the usual yellowish orange color, it is whitish. Now, cup color of the disc, contour of the disc. Contour of the disc will be slightly blurred normally, but if it is like you have made a cut in the retina, it is primary optic atrophy. Very well delineated margins of the disc happens in primary optic atrophy. This disc is pale. It is not normal. So cup is not well seen, disc is pale and pallor, then contour of the disc is it well delineated or slightly blurred, which happens normally. And when there is a disc pallor, you can ask for a temporal pallor, nasal pallor, quadrantic pallor, and pallor of the disc with pallor of the retina. So what is the situation? You get primary optic atrophy is a chalky white. It is chalky white with well delineated margins is a primary optic atrophy. Nasal pallor, what condition you get? Post-papilledemic optic atrophy. So nasal pallor happens in post-papilledemic optic atrophy. Temporal pallor is post-neurotic optic atrophy. Because you have got the papillomacular bundle. No? In optic neuritis, that is the most myelinated fiber, that's the most sensitive, that produces centrocecal scotoma. So it's a papillomacular bundle that degenerates in post-neurotic optic atrophy. So it will be temporal pallor. Whereas nasal pallor, because the vessels are more towards the nasal side. So this edema will be more on the nasal side. So post-papilledemic optic atrophy will be nasal. Then cut out like disc appearance is primary optic. Quadrantic pallor, I left it up. Quadrantic pallor is only one quadrant or one upper part or lower part is pale. That is typically vasculitis, depending on whichever vessel is occluded. Then you can get severe altitudinal hemianopia and severe anemia also. Because the RBC settle down lower. So quadrantic pallor is very diagnostic of vasculitis. Then very clear margin is post-neurotic atrophy, whereas blurred margin is a feature of post-papilledemic optic atrophy. Then you have got a honey-colored disc. That is called waxy pallor. You have heard this term, waxy pallor? So it's a chalky white is primary optic atrophy. Dirty pallor with a blurring of the disc margin and nasal more than temporal is post-papilledemic optic atrophy. Diluted honey color or waxy pallor is consecutive optic atrophy. Supposing you find a waxy pallor or the dilute honey colored disc, you should do the direct ophthalmoscopy using the ophthalmologist ophthalmoscope, because there may be RP in the periphery. It's an indication. It may not be seen in the area which you see directly. It may be in the periphery which we cannot see well with our ophthalmoscope. So that is waxy pallor. And quadrantic pallor or altitudinal pallor is vasculitis. So in this patient, apparently it looks that the temporal area is more pale than the nasal area. With this picture, I'm just doing that exercise.
Yes.
You might have seen it much better. Only the picture I am seeing, you can see the temporal part is a little more pale than the nasal. And then look at the vessels crossing the disc. You should look at the number. You have got an upper division and you have got a lower division, that is there. The upper division and lower division divide in nasal and temporal branches. So those branches, the lower temporal branch appears slightly thinned out. Whether the vessels are having hypertensive change or diabetic changes, that you should look for. Atherosclerotic changes, it is not there. So is there a bearded appearance? So bearded appearance is a feature of vasculitis.
Vasculitis.
Amputated vessels, we'll say one vessel is cut off. That is again a feature of vasculitis. You have the nasal and the temporal branches. One of them suddenly cut off. That is vasculitis. Then ghost vessel, white cord-like vessel. That is also vasculitis. So vasculitis will show beaded vessels, amputated vessels, corkscrew vessels, and that is, and new vessels. All these points to vasculitic change. Even in diabetic, neovascularization indicates significant vascular change. So new vessel formation, corkscrew vessels, and amputated vessel and ghost vessel all point to vasculitis. Otherwise, you will also look for microaneurysms at the venular end or capillaries. That is diabetic retinopathy. So that is the vessels crossing the disc. Then you look at the peridiscal area. In the peridiscal area, if there is papilledema, old papilledema, that is resolving chronic papilledema, then you will find that the periretinal folds, that is called Patton's line, Pattons. The peridiscal area will show folding of the retina, that is called Patton's line. Then you might find peridiscal hemorrhages. Peridiscal hemorrhages can happen in malignant papilledema. You may like what you get in CVT and all, hypertensive encephalopathies, no? And you have macular edema with papilledema or papilledema without macular edema. Papilla, that's very, very important when you work in a rural place. If you have macular edema and you have got macular star, we used to call them macular star. So if you have macular edema and a papilledema, what does it indicate? It's a medical condition. You see, sometimes we forget to record the BP. Sometimes we fail to record urea creatinine. So blood pressure is elevated or a patient has got a kidney disease. So medical papilledema will show papilledema with macular edema. Whereas surgical conditions do not produce macular edema. Macula is the most vascular area. So that is why medical conditions produce signs in the macular region. Surgical conditions spare the macula. So it will be papilledema without macular edema. So that is the vessels crossing the disc and the peridiscal area we have finished. No? So peridiscal hemorrhages, grade 4 to 5 papilledema, there will be hemorrhages. And hemorrhages can happen in bleeding disorders, vasculitis, parapapillary hemorrhages. That is more favoring a vascular. Peripapillary hemorrhages is malignant papilledema. Parapapillary hemorrhages is vasculitis. Then you come to the macula. In the macula, commonly we find macular degenerations, macular star, no? Macular hole, then cherry red spot. So these are something we find in macular degeneration. Coats disease, features of Coats disease for us.
FSHD.
Yes. Then come to the retina. The retina, are there any RP, exudates, hemorrhages, chorioretinal degeneration, Roth spots, tubercles, even cysticercus. Cysticercus can be seen in that part of India. We see cysticercus where you find it in the macula. It will be motile. It will be moving. So very important, you give one tablet of albendazole, patient will become blind. If there is an intraocular cysticercus. So you should describe the fundus like that. So now it is not just cherry red spot. My patient is having some optic atrophy and yes, thin vessels. The branches seem to be less. Even though the superior and the inferior division is there, the nasal and temporal branches are there. There is no sheathing. And in the vessels, I forgot to tell you should look for venous pulsations. So venous pulsations are obliterated means it is papilledema. But the branches appear slightly less. It may be a trophic effect of a chronic optic atrophy. So there appears to be an optic atrophy with cherry red spot, and available retina is not showing any RP or anything. I'm not seeing. So now tell me, so this is how you describe a fundus, ma'am. You said when you are students, you will discuss optic disc, macula, retina, one by one, and carefully focus on everything so that over a period of time, we become habituated to see the fundus. A very important tool, ma'am. Supposing, because people say that a super specialty students training is for helping rural India. We cannot imagine that always we will be working in a center like Nimhans or a big institution where all infrastructure is there. You will have to reach to the rural India, where you depend mainly on your clinical skill. And you should not tell, I don't have an MRI machine, I cannot treat you, patient will die. You see? So you should be, supposing you have a papilledema and you don't look at the macular edema, you will say you seem to have a tumor, you do MRI. Instead, if you see, you carefully look and you pick up the macular star, you will know, you will look for vasculitis or you will look for urea creatinine and you will record his blood pressure and the treatment will be under your hand only. So now tell me, this is a very beautiful cherry red spot. Tell me conditions where you get cherry red spots.
Acute conditions like central retinal artery occlusion and any blunt trauma to the retina, commotion retinae, neurodegenerative diseases like Niemann-Pick disease, sialodosis, Tay-Sachs disease, GM2 gangliosidosis, that is Tay-Sachs disease, Sandoff disease, Farber's disease, and uh, mitochondrial usually with cherry red
Mitochondrial
spot.
disease, you get RP, you don't get cherry red spot.
Some
Mitochondrial disease, you
MNGE
get optic
sometimes
atrophy.
can have cherry red.
Generally, you get only, I am not
RP.
aware, I am not aware that MNG you get cherry red spot, I don't know. As far as I know, mitochondrial disease produce optic atrophy and RP. You see, okay, carbon monoxide poisoning.
Yes,
The,
ma'am.
tell me, Niemann-Pick and all. And there are, without any of these metabolic diseases, also you can have cherry red spot. That is called cherry red spot myoclonus syndrome.
Yes. So these are,
cherry red spot now.
ma'am,
What is the mechanism of cherry red spot?
mechanism actually that the cherry red spot is the normal thing. It is getting the vasculature directly from the choroid, so that the degeneration is happening that the macula in that foveola that is not having this ganglion cells, and the outside these all the things, there is the degeneration of the ganglion cell layer that is causing the pale hue. Because of that pale hue, this foveola is appearing as reddish.
Tell is in a very simple word, you should learn. Very good answer you give. Very nice. Very good answer you give. I appreciate your very wonderful answer. You should tell, but don't use too many words, because you'll not get that much time in the exam, no? So you'll say cherry red spot is due to relative degenerative change in the retina and choroid, where the contrast. So macula gets a more contrast due to pallor of the retina. You saw around the macula, there is a pallor. In the cherry red spot, around that you found the pallor. So it's a contrast due to retinal disease. The disease as such is in the retina. It is not in the macula. Very good answer, wonderful, no? But I always feel that you give examiner the opportunity to ask more questions if you answer precisely in few words, and that will give you gold medal. No, so otherwise, one answer you take such a long circuitous route and explain. So I'll say the disease is not in the macula.
Yes.
It's a relative contrast due to pallor of the retina. That much is enough. Due to whatever cause, it may be central retinal artery occlusion, carbon monoxide poisoning, hypoxic insult. Anesthetic accidents, they get cherry red spot because of hypoxic accidents or any of these metabolic disorders. So good, ma. Good.
So at this time, we thought of patient is having ataxia and this myoclonus and cherry red spot. So one possibility, we kept Niemann-Pick disease based on the age of the onset, but usually Niemann-Pick disease, the age of onset is matching with Niemann-Pick disease type C, but the cherry red spot usually type A and B will usually have cherry red spot. Type C Usually cherry red spot is not seen, and but type C, the patient usually will have most of the patients will have vertical upgaze palsy in Niemann-Pick disease. And the other possibility kept sialodosis 1 or 2 based on the age of the onset and slowly progressive cerebellar ataxia with myoclonus. The most possibility of sialodosis 1 was also kept. Mitochondrial we kept in the later in the list because of there is no family history, and spinocerebellar ataxia also autosomal
You read
dominant.
about cellular spot in mitochondrial disease, huh?
Sorry. We will not get, ma'am. So that
I'm
was
not aware as is because anything can happen in medicine, maybe because you are young students, you may be reading more. But as far as I know, cellular spot is not seen.
yes, only in view of sorry, ma'am. Myoclonus and seizures we kept the differential as math, but cherry red spot usually will not happen in mitochondria.
Hmm.
And normally, apart from cherry red spot, we thought of NCL and Unnervich-Lundborg disease, where the patient Unnervich-Lundborg disease sometimes this lower body may have a cherry red, and NCL even in the late onset also the patient can present with Parkinsonism and a cognitive decline. Those things are not there, but only the spectrum comes
MCL,
under
what is the classical fundus appearance? No?
which one, ma'am?
Anwar Sternberg, if you have seen, no, there it is myoclonus that is a presenting feature. It's not ataxia. Ataxia will be there, but the myoclonus will be very, very disabling. Not like this. Very disabling myoclonus. Even if there is no epilepsy. I don't think the phenotype is matching into Anwar's Lundberg. I don't think so. Then you tell me what is the typical appearance of the fundus in NCL?
Bullseye maculopathy, ma'am.
Good. Very good, ma'am. You have read everything nicely. Good.
So went with the investigations, ma'am. Investigations, complete blood picture, LFT, RFT, and peripheral smear are normal. Vitamin B12 is within normal limits, and thyroid, TSH, T3, T4 is also normal. Nerve conduction studies to rule out any whether sensory or motor involvement it is there, any peripheral nerve involvement, which is normal. EG, there are no epileptiform discharges, and ultrasound is also normal. Why? Because in some storage disorders, we can have some organomegaly. VEP is also normal. MRI brain with whole spine screening was done, with which is with no significant abnormality. So now the patient is having this progressive myoclonic ataxia with myoclonus, so with cherry red spot. Went with genetic testing, ma'am. Keeping in the possibility, the first differential Niemann pick, and but the type and A and B will have cherry red spot, and second differential kept as sialodosis. And the patient came to be
Especially has got visceral involvement. So maybe it will correlate type A is better, no? Possible.
yes. So the patient came positive for neuraminidase 1 transcript positive homozygous, which is sialodosis type 1 autosomal recessive, but it came as a VUS, ma'am, variant of uncertain significance. So then we went with testing for the parents, ma'am. Parents, mother and father, heterozygous. It is present, ma'am. This neuraminidase gene,
Consanguineous parents, no?
ma'am. No, ma'am. Non-consanguineous marriage.
Hmm.
So diagnosis finally progressive myoclonic ataxia spectrum sialodosis was kept.
What are you going to do for her now?
Symptomatic treatment only.
Yes, only the seizure can be controlled, nothing else.
How to counsel, ma'am, this type of patient? Like if the patient wants to get married, so whether actually this is the question they asked.
If they want to get married, one thing they should be told, it's a progressive disease. That should be told, and she should do the genetic testing for the partner so that they don't transmit it to the next generation. Because in India, somewhere we may all be relatives. We
Yes.
don't. So now saying just like this patient, saying non-consanguineous may not be always meaningful. So she has to find out a person who is not having any of these genotypes. And somebody who is willing to marry. Marriage is not against. But these are the problems you have to discuss with them. Otherwise, there is something called if they want babies and they cannot do the genotype testing of the male partner, they will not agree. I am sure they will not agree. Then you will have to do this embryo adoption and all is there, no? If they want to have babies, not have their own babies, if they are not checking the genetic testing for the husband. In case, then you will have to do healthy embryo donation. There is something like that. Embryos can be taken as a donation with some legal issues are there. Because you will be carrying somebody else's child. Later some DNA testing is on, paternity, maternity disputes come. Those issues will be there. So all that should be legally sorted out and they can have. It is almost like an adoption. Their ovum and the sperm belongs to somebody else. And she can become blind, she can become bedbound. So marriage, whether it is, we do not know whether marriage should be encouraged, because I don't think this current era, olden days, I think that people marry and they take care. For some reason, I know people who are married schizophrenics without knowing. Then they lifelong suffer, but because there was some sanctity attached to the marriage in our culture. Now that is not there for practical reasons. So even if you tell and marry and they do not get the real, you know that Gandra General, no, there was one Sadhurveji sir who has done a research and how much understanding a patient gets when you, they get very little understanding. It is of the 100% facts you tell them, they get only some 10 to 14% understanding, even the most educated. That is why most of the patients, you never told this doctor, I did not know. Many times they tell us. As per law, marriage is not prohibited for this patient. What are the consequences of marrying? All those things should be discussed. Altruistically take care. Loss up to the knee. Obviously, so after discussing these facts, you can tell. Instead, best will be check the genotype of the brother. If he is normal, just train her to do the minimal household activities so that he will take care of her. Because blood is thicker than water, we tell. Blood relation is strong. So I think brother will become her strength. These are all my own points I am telling. No, this everybody asks this question. You should, it's a progressive disease. No? So it's a difficult question to answer. If they're educated people, you have to get the partner. If it's a love marriage or something like that, the other kinds of advices I have told you can tell. Otherwise, left to myself, it's a very dangerous experiment. You see, somebody might marry for money or property and then eliminate the person. That's also happens now. I don't know, in rural Karnataka and all, it may not be there. But in many places, we have seen people who try to kill with putting snake into the house of the wife. In Kerala, we have seen like that. So they may marry for some other motive. And they may kill the person who is helpless. She cannot run. She cannot see maybe after some time. All these issues. So ideal, I will tell the brother should take care. And she should not too much cause trouble to the brother. Do some agriculture or something like that where she can be on her own and learn to make her coffee and bread and all those things. So that he will take care. That is my ideal advice. Good, ma, you presented very well. You have read very well. So nice.
Thank
But I will suggest that fundus is such an important tool for us. Always try to explain systematically, then you will pick up so many findings in our fundus. You just quickly put a look at the disc and macula and leave off. No, you systematically go. You saw so many changes are there. Disc is pale, vessels are thin. All those things are there. Then learn to discuss like that. then you will pick up more cases of interesting fundus appearances. So nice.
Thank you.
Presentation. Thank you. Any questions you want, we can ask. Mm.
I think the presenter has prepared for the case and come, I think.
Yes, ma. Good. Very, very nice. Good boy.
Thank you.
Good, ma. You should always be like that because the way you prepare during your student period, later you will not get. Because when you become a super specialty student, already so much family burden will be waiting to be launching on your head. So once you go out, it will be not just academics alone. So many other responsibilities will come. So the time you get to update will be much less than your student period. On that foundation, you build your backbone. So, and brain is somebody's most precious organ. Handle it with care. We cannot be careless, like treating fever or cold. No? So foundation, if it is laid now only, you can safeguard that organ of our patients, no? To the extent possible, not always possible. So good, ma, very nice presentation.
Thank you.
Thank you. Shall we
Thank you,
go?
sir.
Good. Ma.